Hi, I'm Matt Sansing with Disabled American Veterans, and welcome to the first ever Independent Budget Podcast. For nearly 40 years, the Veterans of Foreign Wars, Paralyzed Veterans of America, and DAV have worked together to provide budget recommendations for the Department of Veterans Affairs. And I'm joined today by all of the independent budget partners. Here we have Pat Murray, National Legislative Service Director for the VFW, Joy Ilham, National Legislative Director for DAV, and Heather Ainsley, Chief Policy Officer for the PVA. Thank you so much for being with me today. Heather, I want to start with you here. What is the independent budget and what's the purpose?
Thank you for that question. It's a good place to start, right? So DAV, PVA, and VFW have been working together for nearly 4 decades to produce a comprehensive budget and policy recommendation document on what impacts our veterans through this construct called the independent budget. And so our recommendations reflect what is our best estimate of the funding that VA is going to actually need to meet veterans' demands for the department's services and benefits. And then each of our organizations works together to play a role in authoring and collaborating on the development of those recommendations that then we put out each year, hoping to guide the conversation about where VA's budget will go, which is sometimes a little different than what VA's budget request actually looks like, because we're looking at what do they actually need to provide the services that our members need.
Absolutely. It's a forward look, as you say.
Exactly.
And I want to get into all the recommendations, but first we got to talk about last year's budget seesaw. So in the summer, VA said there was going to have a $15 billion budget shortfall, and of that, including compensation, disability checks. Disability checks would not have gone out on October 1st if Congress didn't appropriate $3 billion in a stopgap measure. How can this happen?
I think that's the question everybody's asking right now, Congress and VSOs included, and veterans, their families, survivors, caregivers. We acted when we saw that there was a need. When we heard that there was a shortfall in the VA's benefits budget, we got together, Congress got together, gave the VA extra money. They didn't end up needing it. I guess we'll say that's good.
Yeah.
And the money is still there waiting for veterans when they do need it. On the VHA side, the numbers have changed. First we heard there was $12 billion shortfall. Now it's $6.6 billion shortfall. And unfortunately, all of this has come together, I think, with a skeptical Congress in terms of what does VA actually need. Understanding that many of us do believe that there is a shortfall, and what that number might be today, I think is maybe an open question.
Absolutely. I think having said that we need funding and then saying we don't need it does not instill confidence for veterans or appropriators or Congress people anywhere.
Especially when we're talking about billions of dollars.
Yeah, the taxpayer dollars.
Exactly.
And we're looking from the perspective of what's happening on the ground, what we're hearing from our members. And PVA has commented often about concerns about specialized care for paralyzed and spinal cord injured veterans. And that's absolutely critical. We can't, with healthcare budgets, these are the lives of veterans that can be at risk when there's a shortfall. A delay in getting, the number right or not getting it right can really impact the health and well-being of our nation's veterans, especially those service disabled and catastrophically disabled.
And that's really important because, for some folks may be able to go and go to another primary care appointment, maybe out in the community or somewhere else that they can access care. There are certain populations of veterans, like the folks that Heather represents, spinal cord injury folks. Those services really aren't available readily out in the community. So it's important that VA gets this right, because that particular group of veterans can't go elsewhere. So that's why that is important, that we're accurate the first time, responsible with the money that is appropriated and given to VA, but that they're also not out here crying wolf, saying that they've got a shortfall, but then they don't, because it is very natural when they're given 4 times to double check, triple check, quadruple check, and they still get it wrong, to then come and say, but we're still short. It is very natural to get skeptical about that. So
that dog don't hunt, as my grandpa would say.
Exactly.
But despite these budgetary challenges, shall we say, Heather, how dire is the need for a properly resourced VA?
So, It's really the difference for some people of whether or not, as we said, they get the health care that they need. They have a monthly compensation check that they're depending on, maybe a survivor benefit, maybe education benefits. This is the difference for many people between having the health that they need and want, having the financial resources they need and want. And VA really can't afford to get this wrong. Congress can't afford to get this wrong. We've seen on the healthcare side, the number of appointments has increased significantly. We have nearly 800,000 veterans who've enrolled in VA care over the 2-year period. So we have more veterans coming into VA, but we also have an aging veteran population that needs more resources in terms of not only acute care, but also long-term care that many folks need as they age. So it really is one of those things that if the VA isn't properly resourced, it is actually an individual that feels that pain. It's not just some government program that somebody really can't name. No, this is a specific person's life that can be impacted by just something as simple as the VA not properly having the money it needs to do the health care that it needs to make sure that somebody's compensation check arrives when it's supposed to. And that's why this is so important.
And as you mentioned, the 800,000 veterans who have enrolled was a 37% increase over the previous 2 years. So what are some of the other contributing factors for more robust services?
I think Heather mentioned, long-term care is probably one of the things that we've been talking about for several budget cycles now. We know we have this significantly aging veteran population, 75-year-olds, 85-year-olds, and the healthcare needs increase and they also change when you age, especially the population that's using VA. For example, service-disabled veterans are high users of the VA healthcare system. We've had 2 decades of war. We have veterans that need, specialized care because they've had a traumatic brain injury, severe, PTSD that they're dealing with, and other consequences of health-related serious wounds. So for long-term care, we want a comprehensive set of services to match their needs, and we need VA to be nimble. It has to project what it's going to need, what is the demand for services. And as more veterans come into the system, we really need to look at that, that impact, because we want to make sure that all veterans who need care are going to get the care they need and when they need it. And the access and timeliness of that care is critical. If it's delayed, that's a problem. Everybody knows if you're dealing with, an aging parent or a veteran that's really in need of home health services, or you need to have them in a more clinical setting, like one of the community living centers for VA. So again, it is difficult, I'm sure, for VA to sort of anticipate and look at all of these different factors, but that's what's expected of them with regard to the budget.
And for veterans to get this care, the VA must be staffed. So how do staffing shortages impact the quality of care, especially for those with more specialized needs? You touched on it a little bit earlier.
I mean, I can instantly just say that one of the basic needs is if you can have beds, and if you don't have the staff to staff those beds, then those beds close. And that's what we're seeing with some specialty care is that they could accept veterans, not that there's no room at the end, but there's nobody there to help you with the proper staffing. So those are just some of the basic things that we see. It can also be things like higher wait times for assistance. If you think about folks with spinal cord injury, or diseases like ALS, they may not be able to do the things that many of us take for granted, like feed themselves, and now have to maybe wait longer in order to get fed because there are fewer people trying to help more veterans, just get through something as basic as eating. So, it can have a really high level impact from delayed appointments to not even being able to get in to just basic stuff once you're in a hospital setting, how quickly you're able to get those basic needs met.
Yeah. In staffing, we've heard about, the concerns over freezing staffing levels or hiring staff. It just seems the demand for healthcare all over the country is high, which includes in VA. And knowing the veteran population as we do, they have exceptionally, chronic health issues that are complex health issues. They require a high level of care and coordination of their care. And the staffing, that does a lot of those care coordination pieces and helps with that is, that's an essential part of it. And I think, too, we were a bit confused this last year about, we had hiring sprints and then we had a hiring pause and it went back and forth. And we were questioning VA. And we will have to continue to do so to make sure the right staffing levels are there to meet demand.
Mhm.
Absolutely. And that demand is reflected in increased medical appointments, right? I think in the independent budget, it says it's a 6% increase, which is the most appointments VA has ever had. Where do these medical appointments come from, and how can VA meet that demand?
So one of the things that, as they touched on, right, the aging veteran population, as you get a little bit older, some of your more chronic ailments continue to get worse, get more pressing. But also, there are more post-9/11 veterans enrolling in VA as well, in numbers that are higher than, percentage-wise of previous generations. It was a really interesting visual that VA put out, I want to say this fall, about what the effects of like body armor and your Kevlar and your water and your magazines do to a human body, right? And it was like a almost an X-ray vision of a human and the compression that happens at the joints when you start adding 10 pounds, 20 pounds, 60 pounds onto someone, not just when you're, in Iraq or Afghanistan, but when you're training that way as well.
In the
That you're
backcourt?
starting that in boot camp now. You train like you fight. So these problems that, previous generations may not have had, now the younger folks are coming in with those, with already difficult physical ailments. Those are not going to get better with age. And so, we'll talk about benefits enrollment here shortly, but the average veteran who was applying for benefits 20 years ago may have only applied for 2 or 3 different conditions. Now they're showing up with 8, right? So that increase is leading to more things that, Uncle Sam did to our bodies that, due to service, and the healthcare may increase with that. So it's not just the aging population is going to need more. The younger population is coming in with more chronic conditions. So we know that this is not something that's going to magically get better, but we have to stay on top of this because, the men and women who wore the uniform have earned this care and benefits.
Absolutely.
And mental health is one area, suicide prevention and mental health is on the top of everyone's mind, especially, the IB, VSOs, and Congress. This is a huge topic that we continue to hear about, and the frustration that we can't see and realize a significant reduction in suicide, despite all of the resources that have been put forth, despite all of the programming. But yet we continue to hear there's a lack of mental health providers, we know, both in the community and in VA. The specialized services that VA trains their providers in terms of evidence-based treatments for treating PTSD, for depression, and other conditions related to, especially wartime service, substance use disorder, and other treatments that veterans really require. All of these things we're seeing increased demand, increased number of people that are reaching out to the crisis line, increased number of people who are trying to get into these specialized programs who have a substance use disorder or co-occurring PTSD and substance use disorder. So all of these things keep compounding. And again, after 2 decades of war, you start to see these things realized, as people age, how they're dealing with their healthcare issues and chronic conditions that can have chronic pain issues, serious mental health issues. And we want to make sure that you get that timely access, because veterans have told us, when I say I want to go for care, I don't want to wait 6 weeks. That's too long for me to get into one of these specialized programs. So we have to try to really look at the budget, meeting those expectations of veterans.
I'm glad you brought up the mental health part, and the Veterans Crisis Line did see a 12% increase over year increase. again, talking about that need. And so far, we've talked about healthcare being in VA facilities within the VA medical centers and whatnot. But let's talk about community care here. When does that come into play when talking about the VA budget? This is up for discussion for anyone.
Community care is a vital component of VA care. It's essentially designed to be kind of like a pressure relief valve. Because VA cannot provide 100% of the care to 100% of veterans 100% of the time. Right? There are people all across this country who are not within hours of a VA facility that need to go to the community. There are certain specialties that VA just doesn't offer these services. So, we need to lean on, our community care providers, but make sure that the system works. There are certain times, if you look at the budget, the community care budget has increased exponentially. A lot of that, if you look at it, is what the VFW is kind of referring to as uncoordinated community care, which is like emergency room visits. Right? If you're enrolled in VA, you slip and break your wrist, you're shoveling snow, you hurt yourself, you can go to, an urgent care. And if it's within VA's network, you can get that reimbursed. But that's uncoordinated through VA. That number is shot up through the roof from a 2020 court decision that said VA had to repay that. So that's a big component of the added cost for VA community care. But also there's a lot of drive time. There are folks in New Hampshire. Every single veteran in the state of New Hampshire is automatically eligible for VA community care because there is not a VA hospital in that state. So an entire state's population of veterans automatically eligible to, go to the community. Now, our veterans in New Hampshire, at least the VFW, will tell you they want you to build a VA clinic near them, so they don't have to do some of that stuff. But where it's needed, we must do it, and we got to make sure it works right. Because whether it's VA direct care or VA community care, if a veteran does not receive care that they're satisfied with, that will erode their trust in the system. That may lead to them not using a benefit or, a service that they've earned. We don't want that. We want it to work right the first time so that when people do have to lean on that and rely on that, it's there for them. Just the same as VA direct care. Our folks have repeatedly told us that, care at VA facilities is preferable, but there are folks that just can't use that. Our veterans in Montana, for example, are 3 hours away from the nearest, VA community clinic. So they have to go in the community. So places like that, we got to make it work. That's the biggest thing that we're leaning on. It's not necessarily more community care. We're not necessarily saying expand it, but where we use it, it has to be good. So it's not a quantity, it's a quality thing. That's what we want to make sure is right.
Go ahead. I was going to say, in terms of budget, community care, something people forget is that a lot of the long-term care VA provides is considered community care. So if you're talking about contracting down to nursing homes, home health agencies, things that VA doesn't provide, they never provided in-house. They work with the community, always have, is part of community care. So I think that, understanding that it's things like, what Pat talked about with maybe my, primary care isn't nearby and I'm going to go into the community, but it could also be things that maybe you have a veteran who gets all their care with VA, but they have a home, they have home care that is through the community because VA doesn't provide that type of service. So it's more complex sometimes than people, I think it is in terms of what's community, what's VA. And that's why we really try to think of, VA being this coordinator of care, VA being the one that is helping veterans get the care they need. And sometimes that's going to mean in the community.
Well, one thing with the independent budget organizations that we've really looked at is this inflection point in where we are with community care. And it isn't just community services, but the impact of not, having enough care or so much care going out into the community where there's an impact on VA's direct healthcare system. So we just want Congress and everyone to be mindful. VA system is really unique. It does provide unique services that you're not going to get anywhere else. High expertise in, war-related injuries and illnesses for veterans. So it's critical that, VA research is not impacted, which is veteran-focused research. The fourth mission where VA really acts as a backup to the nation, and we saw how important that was during COVID. There are a number of things that VA does, the training of our medical providers, which benefit all Americans. So we just want to be mindful and look at the big picture across the board as this community care period, where we're really trying to shore up, fix what's not working right for veterans. Because at the bottom line is that this system is for veterans. It should be about them. They should be at the center of the care.
Absolutely. And there was so much there, but I'm really interested in these New Hampshire veterans who all have automatic access or this right that they can use for community care. I think the point of this is if I wanted to spell it out, if you're a veteran in Sparks, Nevada, and you need a neurosurgeon, you shouldn't have to drive 7 hours to Las Vegas when there's one half an hour down the road, right? I think having those access standards, if I'm remembering back to 2018 with the VA Mission Act, that was a huge part of the negotiation of what we're talking about here. So let's talk about infrastructure now. Pat, where does the VA stand when it comes to their infrastructure?
They're doing horribly. The backlog, what's commonly known as the SCIP list, Strategic Capital Infrastructure Plan, has ballooned over the years. Many VA buildings, hospitals, clinics, things like that are decades old. Within the past, 5-10 years, the list was $65 billion worth of backlogged work, $80 billion, $90 billion, $110 billion, up to $130 billion.
You're recognizing a pattern here.
Yep. Of deferred maintenance, of deferred projects. And it's gone up exponentially, but VA's funding for it, and this is across administrations, across Congresses, has been looking to kind of nibble away at that. There's $130 billion worth of work that needs to get done right now, and they're throwing $2 to $3 billion a year at it. We will never get that done. We need modern, safe, accessible buildings for not just, the folks that work there, but the patients that come in and use those services. VFW members from around the country have told us, and I'm sure many of yours have done the same, that they want, these services closer, more accessible to them. But that may not mean building a VA hospital in every single town, right? That's not sustainable. That may also be an outdated model of healthcare delivery. But, whether it's leasing medical facilities, whether it's building clinics, whether it is building a major medical hospital, that needs to get done. Otherwise, some of these buildings are going to continue to literally fall apart. There is billions of dollars of maintenance, small or minor construction, which is smaller projects under 10 million, and major construction in terms of a big national cemetery or a major hospital. That needs to be prioritized. If we continue to nibble away at this project, we're going to see the backlog list continue to grow, and projects are going to, eke out one by one by one by one. That's not enough. And our veterans deserve more. Even as we talked about, we're not here necessarily to advocate for the workers of VA. It's who they work for, which is the veterans. But they need to be able to work in a safe, modern facility.
Yeah. This has been the most frustrating issue, I think we would all say. We've, talked about it since the beginning of the IB. And again, the infrastructure just continues to age. The delivery of healthcare is different, how it's delivered. And these facilities need to be replaced and several attempts over several administrations have tried with the CARES, the Capital Asset Realignment proposal, as well as the latest sort of air proposal that was in the Mission Act, I believe, right? And they've failed, and that's really failing our veterans. Congress has got to take this issue up and make a decision on what they want to do. And the decision can't be we're just going to continue to ignore this issue and not address it in a way that's meaningful to look at this infrastructure and what it means, because direct healthcare services and clinical staffing, the infrastructure and the clinical staffing are the two things that are key to making sure VA can provide the most care and be the coordinator of care from those facilities. The more that you let that go, the more care you have to provide in the community if these facilities aren't habitable anymore. And we've seen some of the research facilities and others that have been closed, and they're not safe, or seismic issues that exist, and that just goes on year after year after year. So we really hope, and we're really going to be pressing Congress on this issue, and we hope that they'll address it this year.
Yeah.
And right now their plan is kick the can down the road, and that plan stinks.
Yeah.
But they've been doing that now for a couple decades.
Many dents in the can.
Right. And what we've seen, just an example of how, delivery of care has changed. If the spinal cord injury centers are a perfect place for that. We used to have 4-person rooms. Supposed to be good for rehabilitation. You're not alone, stick in a room by yourself. Well, the way in which care is delivered has changed. Oh, and by the way, throw in an infectious disease pandemic like COVID. And now suddenly you have people who get an infectious disease. You have to isolate them. If you've got a 4-person room, well, now you got a 1-person room because we can't have other people in there. And so we have, then we have fewer beds, then we have fewer opportunities to serve folks. So the infrastructure, as Joy was saying, really can inhibit how many people VA can serve as the models of care change. And quite frankly, just the environment of care. I know the average age of a spinal cord injury center is almost 40 years old. That's doesn't inspire confidence. Sometimes you walk in, you're like, gosh, this thing could be remodeled, and so we do want to make sure that that's why the IB put in such a significant increase for infrastructure, because it's one of those things like we're never going to get there unless we actually put the pedal to the metal and start trying to get to the end game here. And if the buildings fall down, there is no VA direct care. I mean, there's no place to provide that.
And Congress has been frustrated. Pat's talked about it a number of times, where VA is given funds and then these cost overruns occur, and they're not managing the funds properly in terms of these projects. And that's another key aspect we really hope this administration will, focus on, because these, we don't want to see dollars wasted. We know that it's a big investment, but our veterans are worth it and they deserve it.
They really do. And if we look at some of the waste, I think the Denver hospital project was maybe the biggest example where they were, I don't know the exact number, how many tens, hundreds of millions they were over budget and years behind schedule, that, they, even when given what's seemingly the appropriate funding, they screwed the pooch on it, right? They did not actually, build that hospital effectively. But, we have to be careful about this stuff. We can't continue to underfund this, underprioritize this. There was a part of the Mission Act, Joy mentioned the AIR Act, which is the Asset Infrastructure Realignment Act, that proposed all kinds of changes to right-size VA to where the veterans are. The VA system was really expanded, post-Vietnam, but the veteran population is different today than it was in the 70s. So, where veterans live is shifting, and the AIR Act and the market assessments were meant to kind of realign and, propose VA assets where veterans are. That bill got squashed last Congress, or the one before? 118th Congress. It had all the potentials to right-size VA for where we need it. We want to see something like that revisited so that we can point to where we're going to not just throw $130 billion at this problem, but where to target it, where to spend it smartly. Not just continue building major hospitals in places that may not need it. Nothing where, it used to be we want to see resources put where veterans are. It's a smart way to spend, so we're not wastefully spending. But that's an important thing we want to revisit, is that AIR Act and those market assessments, so we can focus the finite resources we have towards where they're needed.
So if it is creating this backlog of maintenance projects here, why doesn't the VA include it in its budget request?
It
is, but
at lower rate.
Yeah, as we heard former Secretary Dennis McDonough at, I believe it was a House hearing, said, they had to make tough calls to, meet a budget kind of target. That was in reference to some of the infrastructure low requests. The need is there. If you have a bill, you get a credit card bill and it says it's $100 and you keep putting $1 towards it, $1 towards it, $1 towards it, eventually that's going to continue to grow. What our ask is like a 10-year plan to tackle this project. So that may mean $12 billion a year to eventually get there. And that's what we want to see. We've also heard from other major healthcare networks like Kaiser Permanente that spends 3% of their operating budget annually on their building upgrades and infrastructure, things like that. VA spends 1%.
Wow.
So, the private sector, who we often look at as, the folks that know how to get it done, know how to work efficiently because they're worried about a bottom line. They also want to continue working, keeping their model going. They're spending 3%. So, we're asking for VA to spend more than 1% of their overall budget on the buildings and the bones, the structure, the literal foundation of healthcare.
Brick and mortar places where veterans walk into.
Yes.
Yeah. So what's needed to overcome these VA infrastructure challenges? We talked a little bit about it, but what else can be done?
They have to hire some more people that to oversee more of these projects. They need to fund it at appropriate levels. They need to stop kind of trying to nickel and dime this problem, because it's waiting and delaying and deferring is not going to make the problem go away. It's only going to compound. It's going to get more. It's going to get more expensive. We've seen that with infrastructure across America, right? Look at our roads and bridges and things like that. It's a problem that we all collectively will worry about tomorrow. We can't do that with healthcare.
And one key thing Pat said is people with expertise to manage these projects appropriately are going to be key, because these precious dollars cannot be wasted, not $1. And they've got to have the people in there. VA just hasn't had the expertise in this. They haven't built, over enough facilities to really be able to have a good handle on how to manage these big projects, to make sure they don't get cost overruns and that they're done in a timely way, not taking over a decade to make happen.
And we do need more people, because if you just wrote them a check for $13 billion, VA would not use 10 of it.
It could
Right? Because they don't have the people to also build that capacity that's needed. So it's kind of a two-pronged thing. We got to give them the money, but we also got to give them the people to manage that money, to oversee that money, to implement those projects properly, so that we don't have hundreds of billions of dollars and years delayed on a single project when, we need 30 to be going all at once. Never mind, screwing up one.
Yeah. And we hope it's a priority for all members of Congress, because there are facilities in most states, and they fight for those facilities, so we want to fight for that modernization effort that's been underway. There's a number of things, but infrastructure is a key part of that modernization.
So we talked a little bit about long-term services, but let's talk about that in relation to infrastructure here. What can be done to resolve this imbalance between veterans who qualify for some of these and what they have to go to now?
So I can definitely say, when it comes to specialty long-term services and supports, there are currently 6 long-term care facilities that are for veterans with spinal cord injuries and disorders in the VA care system. Currently, only one of those is west of the Mississippi River. A whole lot of veterans live in that part of the country. We have 2 facilities that are actually under construction right now, one of which will be coming online hopefully this spring, and then one a little further down the road. And those are a drop in the bucket in terms of the beds that are needed. So we would like to see more prioritization within VA's infrastructure. What are things that are difficult to provide in the community that VA needs to provide? One of those is long-term care for people who are on ventilators and need specialty type care. We literally have veterans who are spending more than 1 year living in an acute SCI center setting because there is no facility that will take the individual. They simply require too much care. The reimbursements are too low. Maybe it's not appropriate kind of care. And social workers can't even find a place to put this individual. So they are in a hospital setting for multiple years at a time. So that's really why we have so strongly advocated to say, okay, there are some services are really hard to buy. These are the services that VA being able to prioritize within its own networks to say, hey, how can we make sure that we are providing these services so we don't have veterans taking up an acute care bed for multiple years at a time because there's no place else to put them, actually get them in an appropriate setting and then have that bed be open for a person who does need acute style type care. So that's just one example from a specialty care perspective of where we've seen there are, like I said, precious few projects that are underway, but so much more is needed.
Yeah. And on the women's health clinics, VA has developed an excellent model. A number of facilities do have new women veterans clinics in them. They're wonderful. They provide, the privacy, the security to make women veterans feel safe and wanting to go there, and have all of the latest and newest equipment. And so, that's another key aspect as this women veteran population really increases within VA. And I would mention one last thing on dental care, which we haven't really talked about, but the independent budget has advocated for. Dental care has become, VA is a comprehensive healthcare system. It holds itself out to be a whole healthcare system, but it is missing one real key piece, which is dental care. Oral health is part of healthcare. We all agree. So we'd love to see this expansion within VA of providing dental care, and that requires infrastructure needs as well.
Yeah, there is direct links from oral hygiene to heart disease, for example.
Absolutely.
So definitely.
Serious consequences, and just very few. It's very limited. I think about 800,000 veterans can receive some sort of dental care, but it's really just your 100% service connected or those with independent or IU, individual unemployability, or have a dental
Service connected.
and just a few others. But that's a very limited, and many veterans really struggle to get their oral health taken care of. It's expensive, as we know, and really we'd like to see that as part of the VA benefits package.
But the IB is recommending a significant increase in long-term services. What's behind this recommendation, this big bump?
Well, really, we have the aging veteran population. So when you look at, we have, about 18 million veterans that are living. 8 million of those are over the age of 65. And we have, VA is projecting that its percentage of veterans who are age 85 and older is going to increase by 33%. So we're really starting to see a population, of folks that are, not just living past, retirement, we'll say, but who are living long past retirement. And the longer you live, the more likely, even if you don't have disabilities, your disabilities may, they may exacerbate as you get older. But then if you don't have physical disabilities, you may now acquire them as you begin to age, and need additional support. So we've recommended, I believe it's a $2 billion increase over and above for long-term services and supports, because anytime you're needing somebody to come into your home to provide home care, helping you get out of bed in the morning, getting to bed at night, helping with food prep, helping you with bathing, just basic things that we all need on a daily basis, many of them. We need to be able to make sure that our veterans are taken care of. So you have to have funding to do these types of things. Or if people need to be in facility-based care, having the funding that's available so that folks can access that in their, in their community or through a VA community living center, if that's an option, or state veterans homes, other options. So there is just, when you just look at the population, there is a significant need to make sure that we're not looking just at the acute care situations that folks need, but also that daily support that they might need in order to stay safe, stay healthy, and to be as independent as they can, because most of us want to age and live in our homes, and that's usually more cost effective to be able to do that.
I think that independence is key, something that veterans yearn for oftentimes. And especially our veterans getting older, I'm thinking of our Vietnam veterans here who are living with the long, lingering health aspects of Agent Orange exposure. And as people, as humans get older, they require more care. And veterans are certainly part of that. And the VA must evolve to their patients.
But also, we have service disabled veterans that have had serious injury with TBI, and other very serious physical injuries. And as they age and they lose their support systems in their family, they don't want to lose their independence because maybe they've been able to live with a family member or have some support there. So we've really pushed for like an assisted living component because there are graduated steps and levels to that where, again, you may need just limited support to be able to remain independent. But that's going to change as you age. So those types of unique programs, especially for those who've suffered, war-related injuries, is so key.
Yeah. Yeah, and it's long-term services and supports because it can be over the length of your life. So you may be somebody who's 25 years old, now has a spinal cord injury. You may need help every day getting in and out of bed, meal prep, whatever the case may be. And, if you live to be 85 years old, you're going to need that care now for 60 years. So I think sometimes when people hear long-term services and supports, they tend to think, oh, that's, my grandparents, old people. And particularly as Joy has said, when you're talking about a population of folks who have served their country, wartime situations, this for some people, this is their life, is having those supports and services available. And the VA is kind of unique in some of its ability to provide those supports. So we have to make sure they do it well, because if not, people can suffer in silence in their homes with, well, the aide just didn't show up today, so I didn't get out of bed. Or maybe nobody came, so I didn't get any food today. Again, this is
Heartbreaking stuff.
right. Yeah. This is stuff that, again, we're not talking systems here. We're talking like actual people who then have harm done to them if this doesn't work right. That's why we all care so much.
Yeah, individual stories can tell more than the aggregate ever could. Right?
Exactly.
Let's talk about another critical area here, mental health and suicide prevention. It remains a top priority for the VA and for veterans, quite frankly. What are some examples of the resources that the recommended increase would address in the independent budget?
I think we want VA to continue its suicide prevention efforts and to branch out because they've been trying a number of things, grants with community partnerships, and a number of things. But I think we have to listen to veterans to meet them where they are, whether that's care in the community or with a partner, or in VA, and ensuring that they're going to get the help that they need. Because to look at suicide prevention, for example, we know that I think it's up to 70% of all veterans who do take their lives by suicide do so with the use of a firearm.
Mhm.
And we've said, we can't ignore that. We need to make sure that our veterans are safe. So we need to make sure that they can talk to their clinicians about that when they're in crisis or in a crisis period. We're going to have to look at these hard issues, which are hard and can be somewhat controversial at times. But, VA's trying to develop new programs through its REACH program. So an AI program who's really trying to look at who are at the highest risk for suicide, to prevent that, to go out to them, to do outreach to them. If they show up at an emergency room, VA's required to do a plan of action to make sure that they get to see a mental health provider when they, after that initial visit, and then try to really make a good plan for them for what they need, whether that's inpatient, outpatient care, or a combination thereof. And we know that as a community, all of our organizations have worked to try to say, suicide in the veteran population is all of our business. So we need to look out for each other. We need to make sure we're supporting and we're able to talk about these tough issues. And it is a hard topic to talk about. But if we really want to change the trajectory and reduce veteran suicide, that's going to be essential, I think, for the future. So investing in those programs and services, investing also in making sure more community care options are available when VA doesn't have access are all going to be key in the future.
And something that we really like to see kind of a shift in what VA is pushing is something that is kind of a personal pet peeve of mine when we hear that veteran suicide is VA's number one clinical.
That's what I heard. Yep. They love to say that.
Love to say that it's their number one clinical priority. It's not only a mental health provider problem or solution. We need to look at not just the healthcare aspect of it, but also some of the benefits. What we say all the time, right? If you have food on your table, a roof over your head, money in your wallet, and you're gainfully employed, that helps prevent some of these, negative trends that lead to where we're now at a crisis point. So what we really want more of an emphasis on is that this is not only a mental health, crisis that's a component of it, but there's so much more that VA can be doing through the use of their benefits, right? Whether it's the GI Bill, whether it's some of their employment programs, whether it's housing, things like, the VA home loan or HUD-VASH and SSVF, that we need to focus on what those can also do to help be buffers against that, to make this, whole approach, whole effort to tackle veteran suicide, not simply leaning on it being a mental health clinical issue.
Taking a little more of a holistic view of this. Yeah, I think that's important. And part of that, we talked about a little bit here, is veteran homelessness. Now, the IB here wants to increase for veteran homelessness funding programs, but what we're seeing is very significant drops in veteran homelessness. So how does the need match up there with what we're seeing?
So if you fund programs like the SSVF, which is Supporting Services for Veteran Families, or HUD-VASH, which is Housing Urban Development VA Supplemental Housing Programs, of VASH. Supportive housing. Thank you. Those are things that help veterans, get into some kind of a stable housing. It's better to keep them off the streets than get them off the streets. So there have been some positive news surrounding veteran homelessness, but frankly, one is too many. And it is something that hopefully we can tackle that. It's a problem that has a solution there, right? That is easy to at least identify the solution. It's hard to put into practice. But that's where we need to make sure that this is kind of a consistent approach, consistent effort, consistent priority, so that, even if they've reduced the number of homeless veterans, it's never enough until there isn't a single.
Exactly.
They want to continue to reduce that. And that requires that level of attention and a budget, the resources to do so. It is high intensity resource. Looking at what you have to do, because you're looking at all these different factors. They need healthcare, they need employment, they need housing, it's usually not just one thing. They've really gone down and spiraled down a number of fronts that require attention. And VA does have the resources and has an excellent program. But we also need to make sure that, for example, women veterans can access those resources. So in the community, if a woman veteran shows up with their children, or a male veteran, but they have their children, VA isn't able to provide the housing for them, the immediate housing for them. You may have to coordinate that with the community. So again, community partnerships for that and continued resources will, be needed.
Yeah, several areas of the IB touch on women's veterans. But Joy, I really want to get down to, what does the VA owe to our women veterans?
Great question, Matt. All of our organizations here, VFW, PVA, and DAV, have really highlighted women veterans over the last, decade plus. We've seen more women coming into the service, more women, when they get out of service, turning to the VA for care. And they deserve to have that specialized care that VA can provide. And the one thing, they've done a lot of research in VA on women veterans, so we know a lot about this population and about their unique issues that they face. And we've all been advocating for making sure that they feel welcome at VA, they have access to the same services and programs as their male counterparts, and that VA can train and have specialized clinicians with expertise in women's health. We know that they are a fragment of the population, a very small number, but that has increased exponentially. And they're up to, I think, 900,000 was the last number that we have from VA, with a huge increase just over the last year of women veterans utilizing VA. And that really required VA to expand all of its infrastructure in terms of women's health clinics, get these providers trained, and that's what we've recommended in the IB. We have to continue to make sure that funding goes to having those providers that have expertise in women's health. And they have a wide range. We have a younger women veteran population that's having babies and having families, and we have an older generation of women veterans who have other healthcare needs. And so making sure that those services are there across for their life as well, their lifespan, is important. And we know that VA does have to send out a lot of care into the community for women veterans. So we want to make sure that care is coordinated. For example, there's not enough women for VA to provide maternity care, for example. So that is provided exclusively in the community. And that's fine. And some of the specialty reproductive health services, and that's fine. But then the coordinators of that care are really important to make sure that it's an integrated care system for them as well.
Great. And I got one more question before we take a little bit of a break, but I'd like to hear from everyone here. If there's one thing readers could take away from the independent budget, what should it be?
That we're advocating for the true need of veterans' care and benefits. We've seen in years past that administrations have asked for what they think they should spend, right? Or they're asking for, almost their budget is a target that they're trying to hit instead of a true need. We're not constrained by, the Office of Management and Budget, whereas, the administration is. So, if we say we believe that, this program or whatever it might be requires this level of funding, it's based off of usage. It's based off of veterans. It's not based off of we're trying to stay under a certain target or we're trying to increase to a certain target. We believe what we're asking for is based on the true need. And if you go back and read some of our years past independent budgets, we've actually been a lot closer to what the need for VA that they've come back with supplemental requests. Even this shortfall, we said last year, we believe that they're playing games, that they're, using smoke and mirrors to get to a budget number that people would be satisfied with, but we didn't think that was the true need. Sure enough, they came out in July saying they're short on stuff. And with the additional monies they requested, was actually a lot closer than what we put together than what the administration did.
Well, there you go.
I'm not saying that, we have better numbers in their actuaries and things like that. However, if you'll look at things in 10 years ago about IT requests, we've been closer to what they've needed. About 2-3 years ago, I think we were off by 0.5% with VHA numbers or something. It was very close. Then VA asked for a lower number because they have to stay under administration's arbitrary top lines. That's the biggest thing. We're asking for a true need.
Yep. And as Pat mentioned, I think he said it well, we try to cut through the budget gimmicks. We try to just look at this true need. And we listen to our memberships. We try to really keep our ear to the ground, hear from our members where they're having problems, and where we know there's a backlog in services. And we don't want to be where we were, go back to where we were in 2014. And there's been a number of reports since then that have really verified everything that we've said in the independent budget for years, is that the demand is there. You really need to provide the appropriate amount of resources, especially when Congress is passing legislation. And then making sure that those provisions are implemented in there and additional pressures on VA. So again, that they're not trying to divert funds here and there. And soon all of a sudden you've got, a backlog of appointments and access times are flailing, and they try to, readjust and do something. But if your resources are short, you're going to see that impact eventually somewhere.
And I think, when we start talking about billions of dollars, people tend to get a little, oh my gosh, there must be something in there that you don't really need. Maybe we could save something. And I think what's important about the independent budget, as Pat and Joy were saying, is that we really look at the individual veteran. What is it going to take to get them served? We're not here to serve VA. We're here to make sure VA serves veterans. So when we want, leaders to think about those billions of dollars, those represent veterans. They represent their families. They represent their caregivers, their children, their survivors. Those help them individually. So that, and as a grateful nation that recognizes the service and the extreme uh, payment that many of them gave in service to us, is that we need to make sure that VA is properly funded. That's our only aim. Our aim is not to just make sure somebody at the VA has a job or whatever. No, we're here to make sure that veterans get the care and benefits that they have earned. And it's important that it is reminded that those benefits were earned.
Absolutely. I couldn't have said it better myself. Well, Heather, Joy, Pat, thank you so much for being with me today. And we're going to take a little break. When we come back, we're going to talk about veterans benefits. Stick with us. And welcome back. We're here to talk about veterans benefits. We have Christina Keenan, who is the Deputy Legislative Director for VFW, Marquis Bearfield, who is Assistant National Legislative Director for DAV, and Morgan Brown, National Legislative Director for Paralyzed Veterans of America. Thank you, guys. And I should add that you are all the authors of the independent budget. So first, the independent budget recommends a 20% bump overall recommended for the Veterans Benefits Administration. How have the veterans' needs evolved to justify this increase?
With the increase in claims that recently happened for fiscal year 2024, there were 2.5 million claims that were filed during fiscal year 2024. And in order to keep up with that increase in claims, a portion of that due to the PACT Act with the new service connections that were introduced, over 20 new service-connected disabilities associated with the granting of the PACT Act, that caused the spike in claims. And in order for VBA to be able to keep up with that increase in claims, FTE must be increased, consideration for either mandatory or volunteer overtime should be taken in consideration as well.
Yeah, I mean, we heard with the first group with healthcare, there are more healthcare users. There are more veterans using VA healthcare. And some of that did come out of the PACT Act. So the PACT Act, huge piece of legislation, which has enabled more veterans to access like the wide variety of VA benefits. So not just healthcare, but education, certain education benefits and disability claims, as Marquis mentioned. And we've got this huge group of veterans that came out of the global war on terrorism. So as conflicts, as we had 20 years of conflict, that group of veterans and veterans that came before them are using VA at higher rates. So we're looking at increases in the benefit side, even some of the education benefits as well.
I was going to say, I'd like to pick up on what Christina said regarding education benefits. First and foremost, whether you serve for 2 years or 2 decades, the transition from military service back into the private sector can be very challenging. And so the transition assistance program that VA conducts in conjunction with the Department of Labor and with the Department of Defense, a couple other agencies, and is an extremely important transition tool for military service members. In recent years, there's been a project to kind of revitalize that program, a TAP 6.0 per se. And one of the things that we'll be asking for increased funding for is the necessary funds to put that new transition assistance program into effect. For a veteran with a complex injuries or illness, or a veteran with service-connected disabilities, the VA's VR&E program, Veterans Education and Readiness Program, is extremely important as well. And last year, we highlighted the need for additional resources to support this additional program. In 2024, 137,000 veterans um, uh, filed a claim or attempted to enroll in this program, and that's unprecedented to have that number. There used to be a time where VRE was kind of like that mystery benefit, and we were always wondering why veterans wouldn't enroll in it. The time has come. The word's gotten out. They understand the benefits that program offers, and more veterans are taking advantage of that. And then, in addition to that, you have vocational rehabilitation specialists, which have been added on in recent years to help improve the veterans' use of their education benefits and their GI Bill benefits and the like. We believe that this is be a good opportunity for VA to kind of help grow its own personnel within the VR&E program. So we're asking for some additional funding as well to try to make that happen.
And for folks who don't know, what is the TAP program?
It's kind of complex. So if I miss something, guys, please help me out.
No problem.
Certainly one of the primary focuses of it is to explain to the separating service member and their spouse the benefits and services that they're entitled for. So maybe it's the survivor benefit plan that they may be eligible for, GI Bill benefits, resume services, learning how to dress, learning how to do an interview.
Everything to do with VA benefits.
Insurance programs, employment programs to include VR&E. And being a product of the TAP program myself, I can tell you a lot of the complaints that I had when I transitioned, it's just very interesting to hear that a lot of those same problems are still being discussed nearly 30 years later after I medically retired from my service with the United States Army. So it's very interesting to see that some of those unique situations still haven't been resolved to this day. And with TAP 6.0, hopefully things can improve where departing service members and their families can put themselves in a much better position.
And just to add to that, a part of that TAP 6.0, VA has now incorporated service officers, so accredited claims assistants to come in during one day of that TAP class with VA so that they can offer their claim services to these transitioning service members. Some of the added costs that we're recommending is to coordinate that, to make sure that happens in every TAP class across the country and abroad, just so that can sort of complete the transition to VA benefits by having a specialist there that can help veterans file those claims for whatever kind of benefit that they're looking for. So some of the funding that we're recommending is to facilitate these programs, to staff these programs, and ensure that everyone that's eligible is able to access them, essentially.
I remember when I was in the Army, and I think TAP was an underutilized service, a program. I think I found out about it just after I got out, right? So I think staffing these up, increasing the resources here will just mean that we're able to give service members a much more seamless transition to veteran. But I want to go back to the PACT Act here. We talked about it as if this large expansion of veterans benefits that was passed in 2022. What about it is causing this big increase in veterans seeking benefits?
Well, I mean, part of it is veterans are more aware that they have benefits that they can apply for. So the PACT Act, part of VA's efforts to communicate about the PACT Act has had this byproduct that more veterans understand that they can apply for benefits, that if they've filed a disability claim through the PACT Act, that they may be eligible for new benefits that they weren't prior to filing for those claims. So it's opened up a lot of opportunities for veterans that may have been on the fence or may have been denied some benefits before 2022.
There's also a huge outreach VA did on the PACT Act specifically to get more veterans enrolled, and that increases the benefits. And I think, again, it is often hailed as a burn pits bill, but it is so much more than that. It also expands eligibility for Agent Orange benefits for some presumptive diseases, for example. So it really does touch on multiple veterans, multiple generations of veterans and future generations of veterans. I'd like to talk a little bit about survivors benefits here. Now, what does the independent budget say about survivors benefits?
I mean, generally, I mean, survivors, their benefits have not increased in since some of those benefits were created. So generally, as a group, we're always trying to advocate that survivors get the benefits that they need and that is sufficient to cover their needs, and that they are not an overlooked group. When we talk about veterans, we're also talking about their families and their survivors, and so we're always trying to highlight that those benefits are critical for this cohort, and we support those efforts.
So say one of the changes in survivor benefits that the IB supports is if you're a veteran and you've contracted ALS, and a veteran passes before the 8-year mark, of which the prognosis for survival is only 2 to 5 years. The surviving spouse normally would have been eligible to receive what's called the DIC kicker. It's about $350 more a month in addition to the baseline amount for dependency and indemnity compensation. So by its very design, ALS is a presumptive service-connected disease. So the surviving spouse is automatically eligible to receive DIC. But it's an impossible situation to where the veteran cannot possibly survive just to get across that arbitrary threshold that VA has established, the 8-year mark. So we're advocating that there be an exemption for those surviving spouses, that if a veteran passes as a result of ALS, that they would automatically be eligible to receive the DIC kicker.
Is there anything else about veterans benefits that people should know about?
The one caveat that I would like to add, when you talked about VBA, the very first question you asked, and talking about the additional funding that the IB asked for, the one component that I forgot to mention was about the backlog of cases. And VA strives to have initial claims taken care of within 125 days, or all claims resolved within 125 days. Right now, they're sitting at about 140 days. So those additional funds that we're talking about and the additional FTE that I mentioned earlier, as well as the overtime, will go to help bring that back down to that 125-day window where they would like to have those claims looked at, evaluated, and decisions made. So I would like to make sure that that was part of our conversation as well.
Yeah, I'll also add, we haven't touched in large part about some of the IT needs that VA has, and a lot of that is on the benefits side. So whether it's the faster processing of disability claims or the faster delivery of education benefits, there are a lot of IT needs with the VA's benefits system. Automation, AI, some of these things can really help reduce workload and have decisions come quicker. But we need VA to invest more in making those IT upgrades and long-term investments. So that's another main aspect of the benefits portion that we've covered.
And the only thing that I could think of to add is just a reminder that in many respects, the veterans' benefits that they receive are almost as important as disability compensation. And some might argue even more so important, in the sense that the majority of veterans that we encounter, they want to try to regain, the ability, trying to regain the status in life, become a contributing member to society, become independent. And important programs like TAP, like the GI Bill, that lays the foundation for them to do that. And so it's just extremely important that these programs not only be maintained, but in some cases expanded.
Thank you guys so much. Morgan, Marquis, Christina, thank you so much.
Thanks.
Appreciate it. You can read more about the independent budget at independentbudget.org. Thanks for tuning in.